So we are on live, so I'm going to start off now, sir.
Okay.
Good evening to everyone present here with us today. This is Shreyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. R.Ed, FIMCA, FICP, FDI, FRCP, Edinburgh, Certified Course in Diabetes, recognized by BMJ Royal College of Physician and Fortis. C. Sir is a senior consultant physician, director of Chhabra Medical Center, Pritampura, Delhi. Max Shalimar Bagh and Saroj Super Specialty Hospital, Delhi. Sir is also a founder president of North Delhi Physician Forum, Delhi. Past faculty member, Indian College of Physician, API, and member editorial advisory board, JAPI. Sir is also a past chairman and secretary at API Delhi State Chapter, past treasurer and executive member, CSI Delhi branch, state executive member, IMA DNZ, publication in national and international journals, and ex-governing member, Association of Physicians of India. Now, without any further delay, I would like to welcome Sir to discuss today's topic, which is tips in the management of diabetes in day-to-day clinical practice. Over to you, sir.
First of all, I would like to thank you, MedTalk and the IJCP for giving the opportunity, and especially thank to the Serium and the Ankana Chatterjee. And today I have been allotted a very important topic, that is diabetes mellitus. You are seeing that diabetes is a big problem globally and the Asian, all over the world. It is a global problem. How to manage, how to handle. It is a big problem for the patient as well as for the doctors. How to manage this? Today I will discuss what are the tips, what are the uh, tips how to handle the management of the diabetes mellitus. So first of all, I would like to tell you about the diabetes. What is the diabetes? So diabetes in India, it is an epidemic. So estimated number of the people with the diabetes based on the oral glucose tolerance test criteria in the India in 2021 is was the 101 million. And overall diabetes prevalence ranges across the state is the 48% in the Uttar Pradesh to the 26% of the in the Goa. So high prevalence translates to the large population at the risk of the cardiovascular disease and the chronic complications such as the kidney, foot, and the eye disease. So in short, the prevalence of the diabetes in India is considerably higher than previously estimated, and will continue to accelerate. In the coming term, the number of the diabetic patients will increase globally, especially in India. So how to handle the disease, any disease, like the management of the diabetes, it starts from the prevention, diagnosis, treatment of the complication, because so many complications, if we don't control the diabetes, then lead to the complications. So if we talk about the prevention of the diabetes, it is only the myth. We cannot prevent the diabetes. What are the diabetes which can be prevented? That is stress-induced diabetes. The person who remains on the stress, if stress is over, then diabetes will cure. And drug-induced. Sometimes we take the drug which induce the hyperglycemia or the diabetes. If we stop the drug, the diabetes will go. And similarly, the prevent the risk factor only. If the diabetes is due to the obesity, then you control your weight and reduce your weight, then definitely diabetes will go. What is another the syndrome? That is a false diabetic mellitus. Sometimes if you eat more or the sugar or the carbohydrate, then that will lead to the hyperglycemia. If you stop the sweets, then definitely it will go. Diabetes will not be there because it is a false diabetes, pseudo-diabetic. So dear friends, the diabetes, it is a disease, it is a chronic disease which can be controlled if it is there. So we cannot remove the diabetes. Nowadays, There's a halla gulla, there's a reversal of the diabetes. I will tell you about the reversal of the diabetes. But in the if the patient is diabetic, we can control only the diabetic patients. So, dear friends, if the management of the diabetes mellitus was so simple in the past, when only the glycemic control was the concern at that time, we diagnosed the diabetes with the blood sugar fasting as well as the PP, and we do the sugar in the urine that will make the diagnosis of the diabetes mellitus in the past. When we were the student, at that time, we managed the diabetes with the conventional treatment, either the oral drugs. Few drugs are available at that time with the bovine insulin at that time. We use the bovine insulin at that time. So that was very simple when only the glycemic control, only blood sugar control is the concern. After that, with the advent of the science, then is the glycemic concern suffice in the management of the diabetes? If you ask this question to everyone, every doctor will agree with me, because answer is the big no. Then what are the other challenges or the concern in the modern era in the management of the diabetes mellitus? When in the age of the patient, especially in the elderly patient, if the patient is old in the old age, then the diabetes management is different from the younger generation. If the duration of the diabetes is so long, the treatment of the diabetes will remain the different from the acute problem. If the blood sugar is very, very important. Fasting and when the postprandial, the PP, that is known as the PP sugar. Another is the HbA1c control. If we have to control the HbA1c, we have to keep the HbA1c between the 6 to 7 according to the ADA or the ESDI. So the another the glycemic variability, because we found the glycemic hyperglycemia, sometimes it comes down and sometimes it is, there is surge of the hyperglycemia. So there is definitely variability in the glycemia. So another is the weight. If weight gain or the loss of the neutral, it will come the concern in the management of the diabetes mellitus. Another is the hypoglycemia. Hypoglycemia is a big problem during the management of the diabetes. Once the patient is going to the hypoglycemia, he will not accept your treatment because वो कहेगा डॉक्टर साहब ने मेरे को इलाज कर दे दिया, हाइपोग्लाइसीमिया हो गया तो आपको एक्सेप्ट नहीं करेगा ट्रीटमेंट. सो हाइपोग्लाइसीमिया इज बिग कंसर्न इन द मैनेजमेंट ऑफ द डायबिटीज mellitus. If you see the insulin therapy, everybody is agree with me. Insulin therapy, once you say the patient insulin chalu karni padegi, he will change the doctor and he will not accept the insulin therapy. Another is the comorbidity. If there is a cardiac element is there, or the renal disease is there, or the hepatic disease is there, the treatment of the diabetic will become the different from the normal patient or the without the comorbid condition. So it is also concerned in the management of the diabetes mellitus. So another the cost, because we are the Indians, cost remains a very big factor in the management of the diabetes mellitus. So now another problem we have faced, the COVID-19 pandemic or the lockdown we have faced, how difficult to treat the patient in the COVID era. So it becomes also challenging at that time. So dear friends, what is our primary goal on the type 2 diabetes management? Our goal is maintain near normal blood sugar level and prevent the micro and the macrovascular complication. If you prevent the micro and macro, all the problem will go, either stroke or the heart disease or the renal disease, renal diabetic nephropathy, or the diabetic stroke or the heart attack, all will be decreased, or we can prevent. These are the complications we can be prevented. So dear friends, we have to hit early and hit hard. We have to control the glycemia, hyperglycemia, effective glycemic control with the cardiorenal protection. We have to protect especially the cardiac and the kidney protection. So dear friends, how to diagnose the diabetes? The big problem. We diagnose nowadays. We diagnose the diabetes with the fasting AP and the random sugar. Fasting must be with the range of the 60 to 100 milligram, and PP less than 200 milligram, and random less than 140. So according to the glucose tolerance test, we do the blood sugar at the 0, half an hour, 1 hour, 1.5 hour, and 2 hours. And sugar in the urine, it is we are not doing the sugar because there are so many drugs which causes the glycosuria. So nowadays we are not using the sugar in the urine for the diagnosis. So dear friends, what is the diagnosis of blood sugar? Fasting, the criteria. Fasting sugar must be more than 126 and PP more than 200. Then we can label the patient is diabetic mellitus. Then you will ask, what about if the blood sugar is the 101 to the 125? So this is a pre-diabetic condition. This is the right time to take the precaution or to prevent the diabetes, because with the passage of time, you will develop the diabetes. This is the only you have to change your lifestyle and the diet management. Then you can control the pre-diabetic condition. In this pre-diabetic condition, the micro as well as the macro, both complications starts in the pre-diabetic stage. So by the time of the diabetes diagnosis, 50% of the beta cells will go if you diagnose the full-fledged diabetic. So another, in the glucose tolerance test, we give the 75 grams. We take the sample I have told you. Then if there is more than 200 milligram, if there is 100 to 126, then it is impaired fasting glucose, and PP if it is 141 to the 199 sugar. So stepwise approach in the management of this, how to approach. This is the only tips. Now I will give the tips for where the diagnosis, you have to see the patient always do the PP after the 1.5 hours. You should instruct the patient, you get your blood sugar PP after 2 hours, because the most of the lab technician, they call the patient at the 1.5 hours. That is wrong. We should call the patient after the 2 hours. This is the right method. Another thing, sometimes patient do the fasting on the one day and the PP on the another day. These are tips. You should ask the patient, you get all the fasting as well as the PP on the same day. If suppose fasting is PP on the one day, it's 100. Another day, the fasting is the 120. And according to the PP will come according to the fasting level. So we should ask the patient to get a fasting as well as the PP on the same day after the 2 hours. So this is the tips to diagnose the patient in the diabetic mellitus. So the management of the approach should be integrated. We should start the management from the lifestyle management, that is the nutrition, exercise, then the pharmacotherapy there. This is the flow of the management. So the key component of the diabetes self-management is the nutrition. I have told you, individualized eating plan, because it should be individualized, and diabetes specific nutrition, sometimes it may be needed. That is the glucose monitoring. Nowadays, the continuous glucose monitoring and the weight management, there is a physical activity, another is the pharmacotherapy. In the pharmacotherapy, oral hypoglycemia or the injectable. Nutrition, physical activity, or the exercise and pharmacotherapy play a synergistic role in the diabetic management. So dear friends, with so many considerations, we have no control on the patient's compliance or the adherence to the treatment. Most important concern is the management of the diabetic mellitus. If patient is not adherent or the compliance to the treatment, the hyperglycemia cannot be controlled at all. This is a big problem nowadays we are facing. So that may lead to the complication. What are the complications? That is the burden due to the diabetes. Diabetic complications are the coronary artery disease, peripheral vascular disease, retinopathy, and nephropathy, and the neuropathy. In the rural area, the neuropathy and the retinopathy and the peripheral vascular disease are more prevalent than the rural area. But in the urban area, the coronary artery disease and the nephropathy, there are more than the rural area. This is the complication, because in the rural area, they go the barefoot. So that is the problem in the rural area. So dear friends, reduction in the tightly controlled clinical trials are not being translated into the real world HbA1c outcome. Because study, There is a difference between the clinical trial and the real world trial. If you, in the clinical trial, if you see the reduction of the HbA1c over 1.25, 0.5, but in the real world, it is a 0.52%. So this is the gap that is known as the efficacy gap. What is the efficacy gap? You see in the clinical trial, the reduction is 1.04, and in the real world, it is a 0.52. But what is the gap? This is the explaining the gap. This 70, but this gap, the efficacy gap, 75% this gap is due to the non-adherence to the treatment. That is a big problem in the, especially in the India, because they don't adherent or the compliance to the treatment. That's why they lead to the complications. So dear friends, what about the exercise? What we are doing? We are not doing such justified to our treatment, because the remotes comes from the outside, the out of the country. They do the exercise like this exercise they do. But the India, we are using the remote. We are not doing the exercise. On the Sunday, we wake up in the late in the day. We wake up at the 10 o'clock time. So we are not regular in the exercise. Then we should not use the remote, because we have to do the exercise. We should go out outdoor activity. So the physical exercise must be good to control the diabetes mellitus. Similarly, if you talk about the yoga, there is a difference between the real yoga and the political yoga. This kind of the yoga is the I will say it is a political yoga, because these are the politicians. They come on the election day only. This is the banner they are putting, and they are doing the yoga without gap. They are sitting together. So this is a note way of the yoga. This is stagnant water. They will there will be dengue or malaria, whatsoever. This is the political yoga. If you want to do the yoga, you ask the patient do the yoga in the proper way to control the diabetes mellitus. This is the type of the yoga. If the patient do like this yoga, then he can or she can control the diabetes. Otherwise, no. So in this, the yoga must be like this to control the diabetes mellitus. Otherwise, this is a tip. You should explain the patient. The exercise is very, very important in the management of the diabetes mellitus. Before the physiotherapy, these are the very important physical activity as well as the yoga. Both are important to control the diabetes mellitus. Similarly, if we talk about the pharmacotherapy management of the diabetes in the modern era, if you see there are numerous anti-diabetic drugs, either oral or injectable. We are confused which drug we have to use. We always see what are the advantages of the drug, and we are confused which drug should be used. We are special about so many companies, but we have to use with our clinical trial or the study, or we have to see so many guidelines, then we use the drugs. So either monotherapy, combination therapy, or the co-formulation. These are the drugs which are using in the diabetes mellitus. What is the tips? In the tips, what are the concerns while choosing the drug for the treatment of the diabetes? What we see before starting the treatment is very, very important. If you don't see, then you cannot treat the patient in the proper way. What are the drug should be approved by the authority, as the FDA or all the authority. It should be approved by the authority. Otherwise, we should not use the drug. And it should be efficacious to control the both fasting as well as the postprandial blood sugar. And similarly, HbA1c reduction must be there to keep it on the target level. So HbA1c reduction, the drug should be used, the drug should be used on only those. And pre with the minimal chances of the hypoglycemia, because once into a patient goes into the hypoglycemia, they will not start again or restart the treatment, because hypoglycemia is a big problem. Similarly, if there is a glycemic variability, the glycemic will lead to the complication. The glycemic variability should not be there. There is no research of the hyperglycemia during the treatment. It should be a plateau, or there should not be variability in the blood sugar level. So another weight neutral or the weight loss property. The drug should not increase the weight or the insulin or any drug thermonuria. The weight should not be gained, because if there is increase in the weight, definitely the obesity and the weight gain, overweight always lead to the insulin resistance that will obstruct the treatment of the blood sugar cannot be controlled if there is obesity or the overweight. Similarly, it should be easily available. ऐसा नहीं कि आपने दवाई लिख दी वहां जाके नहीं मिले. दवाई, it should be available everywhere, easily available. And what's the economic? As I have told you, in the Indian scenario, the economy is very important because if the costly medicine, you right, patient will take for the 10 or 15 days, then he will stop. You should keep this point in your mind before starting your treatment, because it is a chronic disease. The treatment will go for the long time. The patient should accept the economy of the patient so that patient can take the drug in the proper way and for the long time. Similarly, dose convenient. It should be a minimal dose because we use the combination to reduce the pill burden. So dose convenience should be there. Preferably, it should be given in the single dose. That will be better. Otherwise, patient will not accept to enhance the adherence or the compliance. So dose convenience must be there. Otherwise, patient will not take the medicine regularly. Similarly, it should be well-tried drug with the full safety, especially of the renal cardiac. This is a very, very important page because the drug should not harm either the kidney or the heart. It should not be harmed. It should be safely used in the cardiac ailment or the renal ailment. That drug will be always better to treat the diabetes mellitus. Similarly, what about for the OAD? Two pathways are there. We are using nowadays two types of the drugs. One is the insulin dependent pathway, another is the insulin dependent pathway. Non-insulin dependent pathway. The insulin dependent pathway, all the drugs, that the DPP-4 inhibitor, sulfonylurea, metformin, or any other drug, all the drugs are the insulin. They either sensitize the insulin or that they increase the secretion of the insulin. That will do the work according to they are dependent on the insulin. These are the only drugs, DPP-4 inhibitor in the intestine, in the kidney. They work through the insulin pathway. Nowadays, we are using very frequently that is the SGLT inhibitor, that is the non-insulin insulin pathway drug, that is that we call the glycosuria. Because sometimes when it was started, the patient, Dr. Sahab, मेरी sugar तो बड़ी आ रही है, 4+4 आ रही है. Because we are using this drug, definitely there is a sugar in the urine. That's why we are not using for the diagnosis in the diabetes mellitus. It's a SGLT2. Two types of the drugs are there. Similarly, you should know this type of the hexagon, what are the mechanism of the hyperglycemia. Then you can use the drug accordingly. If you don't understand this mechanism, then you cannot use the respective or the concern, the targeted drug in the management of the diabetes mellitus. One is the drug that is decrease the insulin secretions. There is a decrease in insulin due to the damage to the beta cells, that will cause the hyperglycemia. Decrease the incretin factor, that will also hyperglycemia. Increase the lipolysis, that will increase the hypoglycemia. If there is a reabsorption of the sugar, that will cause the hyperglycemia. Similarly, there is a decrease the glucose uptake, that will lead to the hyperglycemia. Similarly, neurotransmitter dysfunction or the increased glucose production, that will lead to these are the 8 mechanisms, or increased glucagon secretion. All these will increase the hyperglycemia. We have to see which is the defected, then we have to give the drug which act on this system, that then we can do the diabetes mellitus. Similarly, you see, these are the drugs which are the acting, the sulfonylurea, TZID, or the GLP-1 receptor agonist, or the DPP-4 inhibitors. These are drugs which are causing the insulin. They decrease the insulin secretion or increase the insulin secretion through the intestine, and these are the drugs, the GLP-1, the causes the intestine or the dysfunction. These are the different drugs which we are using. So you should remember this chart or the picture to use which drug should be given in the particular patient. Every patient will be given the different drug of the drug. So no single anti-diabetic agent can correct all the pathophysiological disturbance present in the type 2 diabetes mellitus, and therefore the multiple agent will be required for the optimal glycemic control. Similarly, neither metformin, sulfonylurea, or GLT-2 inhibitors or the DPP-4 inhibitor can bring down the HbA1c to the target, the many diabetic patients. That's why we have to use the combination. So early intensive control of the by the dual therapy without precipitating the hypoglycemia. You should keep in the mind hypoglycemia should not be there. It's anticipated to yield a lesser long-term complication, as I've done in the both, according to the DCCT or the EDCC or the UKPDS study, metabolic memory or the legacy effect. These are that you have to remember. Similarly, when we use the combination from the starting, when to initiate the combination therapy, what does the guidelines say? Initiate the combination therapy. Early combination therapy can be considered to extend the time to the treatment failure. So should not be failure early with the HbA1c level 1.5 to the 2% above the target level according to the ADA 2022. And similarly, entry of the HbA1c, if there is a HbA1c more than 9 or the 1.5 above the target, then should consider the dual therapy or the combination therapy according to the AAC or the Assessment of the clinical endocrinologist according to the 2020. And similarly, in the younger people with the diabetes, type 2 diabetes, in whom the stepwise approach would delay the access of the agent that provide the cardiorenal protection beyond the glucose lowering agent according to the AC or the ACE 22. And considering the initiation of the combination therapy, if the HbA1c 1.5 above the target level according to the RSDI 2026. These are latest guidelines according to the RSDI. Similarly, in the last, what are the challenges in the insulin initiation? Very important. The clinical inertia, patient training or the education requirement, or is the hypoglycemia. These the clinician afraid of the losing the patient. So this is the according to the doctor's perspective and the patient perspective. Always think there is stigma, fear of the needle, need to more intensive monitoring, or need to greater regimen, or the fear of the hypoglycemia, fear of the weight gain, or therapy of the lesser resources. So similarly, insulin, we start the OPD and the hospital diagnosed patient or the undiagnosed patient, newly patient, or the emergency or the pregnancy. These are the challenges in insulin therapy. We have to start insulin therapy. We have to say the patient, you start the insulin, bring your hypoglycemia, then we can start the oral drugs. So insulin, we have to convince the patient. We have to give the time to the patient to convince for the insulin therapy. So these are telemedicine. It was the we faced during the COVID era. And so the telemedicine we have faced the challenge in the insulin therapy. Similarly, monotherapy, rapid, these are the insulin we use, and these are, we should know about the onset and the onset peak and the duration of the all the insulin therapy. Similarly, type of the insulin, we should know about the all the insulin. Similarly, long acting or the long acting analogs, we should know about. If they have, then we have to convince the patient, then we should start the insulin according to our comfortable or the patient comfort. On the dose convenience must be there. So similarly, in the important fact of the life, I will tell you a big difference between the money and the time. We always know how much money we have, but we never know how much time we have. So value the time. Let us value the time. We should control the diabetes well in time. Similarly, about the management of the diabetes mellitus, a big difference between the control of the disease and the complication in the future. We always know how much control of the diabetes we have, but we never know about the future complications of diabetes mellitus. So dear friends, let us always value the strict control over the diabetes mellitus to avoid the complication. So we have to control the tight control of the hypoglycemia to avoid the complication in the need of the hours with the broad vision attitude. Beware of the tubular vision. We should think about everything, kidney, comorbidity, age of the patient, duration of the disease, weight, and HbA1c, hypoglycemia. We should think each and everything. With the broad vision, we have to treat the diabetes mellitus. We should beware of the tubular vision. If we treat the diabetes mellitus with the tubular vision, if you use the tubular vision, you see is a big, very beautiful film. If a picture, but if we see with the broad vision, it is not big, beautiful picture, but it is a bull. So beware of the always tubular vision. You should treat the diabetes mellitus with the broad vision and be holistic approach. It should be there to treat the diabetes mellitus. So, dear friends, superior doctors prevent the disease, and mediocre doctors treat the disease before evident, and the inferior doctors always treat the full-blown disease with the complication. So, dear friends, what is the take-home message? I will advise you: stay as a superior doctor. Try to prevent the diabetes mellitus. If the diabetes is there, then you treat and keep the tight control of the hypoglycemia to avoid the complication. The complication should not be there. Otherwise, you are the inferior doctor. You be a superior doctor. You treat the diabetes mellitus. So, if the disease is evident, then treat to avoid the complication. So, thank you very much. Over to the organizer for the question answer session. Over to the.
Thank you, sir. Thank you so much, sir, for your wonderful presentation. So, sir, we do have some questions from our audience.
I just finished in the half an hour, I think.
Yes, sir. So, sir, the first question is, are there any promising developments or research findings in diabetes management that clinicians should be aware of?
But we have come with so many drugs which are very, very important without the hypoglycemia, and very good drug with the low cost. Nowadays, a patent is being lifted, and all the drugs are available, which causes the less hypoglycemia. So you should use the hypoglycemic less on the less variability. Glycemic variability is very, very important nowadays. With the time in range, we have to keep the patient time in the range. That there should not be variability. Otherwise, complication will occur.
Thank you, sir. The next question is, how do you address medication adherence issues and encourage patient engagement in their treatment plan?
Very good question. I don't know किसने पूछा है. A very good question. Because we have to start the medicine, I have told you what we keep in the mind to choose the drug. We have to keep the economy of the patient, another the safety of the patient. We have to see the comorbidity of the patient. If either patient is having the cardiac ailment or the renal ailment, whatsoever we have to choose the drug so that patient can adhere to the treatment. Adherence or the compliance to the treatment is very important. Otherwise, the tight control of the hyperglycemia should not be there, and complication definitely will occur. We have to keep the group discussion of the patient so that adherence can be. Adherence, 75% of the failure of the treatment is the non-adherence or the compliance to the treatment. So first of all, we have to keep the patient, adherent to the treatment. And we should tell them the diet management. But we should tell them the lifestyle management, because it is a lifestyle disease. If there is obesity, then reduce the weight. These are the very, very important. We are overlooking this step. Diet is very, very important. Don't say them to skip the diet, but it should be calculative. It is a sugar-free diet.
Thank you, sir. The next question is, how do you integrate digital health tools and app into your practice for better patient engagement and monitoring?
I was expecting this question. Digital is very, very important, because even the glucometer we are using, that is a digital management in the management of the diabetes, very, very, very key, because patient is at the home. So in the night, if patient is having the hypoglycemia, then they can do the digitally blood sugar level. Then if there is hypoglycemia, they take the sugar, and the hypoglycemia can be corrected at the home. This is the only. Another is that nowadays we are talking about the continuous blood glucose monitoring. That is very important. That will tell us at which time hypoglycemia is there, at which time the surge of the hypoglycemia is there. So digital method of the diabetes management is very, very important, and which help us to manage the diabetes mellitus in this era.
So the last question from our audience is, what challenges do you face when incorporating technology into diabetes care, and how do you overcome them?
First of all, lack of the knowledge about the digital, how to incorporate this, number one. Number two, the cost of the digital uh, gadgets is very, very important because patient cannot, we are in the areas, we are the area we are residing, the cost is very, very important in the digital media and lack of the knowledge, lack of the education about the digital media incorporated in the management of the diabetic mellitus. These are the two uh, challenges in the digital incorporation in the diabetic management.
Thank you so much, sir, for answering all our questions. Before concluding today's session, any last remark from you?
My last remark is you should control the diabetes as soon as possible and ask the patient to adhere to the treatment. If patient is adherent to treatment, then definitely the glycemic control will be there. Adherence is very important, I will say. You should call the patient and you should keep a connect with the patient and you should give the time to the patient to control the diabetic mellitus because it requires the very good time to convince the patient about the treatment and especially if you want to add the insulin therapy.
Thank you so much, sir, for joining us today and for this wonderful session. Hope to see you again, sir. With your permission, I would like to conclude today's session. Thank you.
You can conclude. Thank you.